Hello everyone. In this presentation, we will discuss the static and functional characteristics of normal occlusion. We will discuss about the 6 elements: orthodontics, cusp fossa, and cusp embrasure occlusion, various static characteristics of normal occlusion, in which we will discuss in details about Andrew's 6 keys to normal occlusion and dynamic or functional characteristics of normal occlusion. You all know that orthodontic treatment usually targets 3 primary areas. The first is teeth or dentition, the second is maxillary and mandibular skeleton, and the third is orofacial musculature. In this presentation, we will discuss only about the characteristics of normal occlusion. In 2015, Andrews introduced 6-element orthodontics, which says that there are 6 different areas in the craniofacial region to be considered in the treatment goals. All 6 of these areas must be normal or in harmony for optimum orthodontic results. In other words, if these 6 different areas are not in harmony, then optimum results cannot be achieved. Thus, it is very essential for an orthodontist to define the treatment goals for providing high-quality orthodontic care. Also, it is important to visualize the end from the beginning of treatment. That means what you want to achieve at the end should be in your mind before the beginning of treatment. You all know that Andrews introduced 6-element orthodontics in 2015. The 6 elements orthodontic treatment goals are I. Optimal tooth and dental arch characteristics. It deals with the shape, size, and number of teeth in the maxillary and mandibular arches and dental arch forms, etc. Unless all these things are not normal, optimal occlusion cannot be achieved. Optimal anteroposterior jaw positions. There should be a class 1 sagittal relationship between maxilla and mandible. If jaw bases are not in harmony, then it becomes difficult to achieve normal inclination of the upper and lower incisors. 3. Optimal jaw widths. Optimal width of the mandible should be in harmony with the width maxilla. It is very much essential for achieving the normal inclination of posterior teeth. Optimal jaw heights. The upper anterior facial height should be in harmony with the lower anterior facial height, and total posterior face height should be in harmony with the total anterior face height. If face heights are not in proportion, then it will affect the inclination of the occlusal plane. Optimal chin prominence. 6. Optimal occlusion. The optimal occlusion involves elements I to V and 6 keys to normal occlusion. Thus, for optimal occlusion, elements 1 to 5 must be optimal. All these features together are essential for optimal aesthetics, function, and healthy occlusion. Now we will discuss a little bit about the cusp fossa and cusp embrasure occlusion. According to Charles Stewart, there are 2 limits of occlusion. One is a mesial limit, which is known as tooth-to-tooth occlusion, and the other is a distal limit, which is tooth-to-two teeth occlusion. According to Huffman and Reginos, the mesial limit of occlusion is also known as cusp fossa occlusion, and the distal limit is known as cusp embrasure occlusion. In cusp fossa occlusion, as shown in the figures, the palatal cusps of maxillary posterior teeth occlude with the fossa of mandibular counterpart, and buccal cusps of mandibular posterior teeth occlude with the fossa of maxillary counterpart. This type of occlusion is particularly advocated by restorative dentists to allow each centric cusp to be surrounded by 3 opposing triangular ridges, thus offering tripodization to stabilize and hold centric. The advantages of cusp fossa occlusion are: 1. The occlusal forces are directed along the long axis of the tooth, thus forces are more physiologic in nature. 2. The stability of the occlusion is better. 3. There will not be any food impaction on the interdental areas. And 4. Less occlusal wearing attrition. However, the major disadvantage of cusp-fossa occlusion is that in this occlusion, maxillary teeth remain slightly mesial of Angle's class 1 relationship. As a result, it compromises the anterior guidance. However, in natural dentition, this type of occlusion does not exist unless all the teeth are reshaped. Now we will discuss cusp embrasure occlusion. In contrast to cusp-fossa occlusion, in this type of occlusion, buccal cusps of mandibular posterior teeth, as highlighted by the blue color arrows, contact maxillary embrasures. Similarly, the lingual cusps of maxillary posterior teeth occlude in the fossa of the mandibular counterpart. In this occlusion, each maxillary tooth remains distal and facial to the mandibular counterpart. In this cusp embrasure occlusion, Angle's class 1 molar relationship is well maintained, along with excellent anterior guidance. The only argument over this occlusion is the plunger cusp to marginal ridge relationship and the ability to hold centric without tripodization. From here, we will discuss the static occlusal goals of a normal occlusion. When we discuss the static occlusal goals of a normal occlusion, Andrews's 6 keys are considered as a complete set of indicators for optimal static occlusion. All these keys can be judged from landmarks that are present in facial and occlusal surfaces on clinical crowns. The absence of any of the following 6 keys results in an occlusion that is inferior to an optimal occlusion. Thus, for optimum static occlusion, Andrew's 6 keys must be achieved. Key 1. It is molar relationship. For optimal normal occlusion, the molar relationship should be Angle's class 1. To say Angle's class Y molar relationship, 3 criteria must be fulfilled. Criteria 1. It is the mesiobuccal cusp of the maxillary permanent first molar must occlude in the developmental groove between the mesial and middle buccal cusps of the mandibular permanent first molar. Look at these pictures and remember this relationship. Now we will discuss the second criteria. The distal surface or distal marginal ridge of the distobuccal cusp of the maxillary permanent first molar should contact and occlude with the mesial surface or mesial marginal ridge of the mesiobuccal cusp of the mandibular permanent second molar. Look at the last picture. See the angulation of the maxillary permanent first molar. When there is good contact, the maxillary permanent first molar should have slightly distal angulation. Remember, if the first molar is very much upright, then it becomes difficult to fulfill the second criterion. In the previous slide, we discussed the second criteria. Now you compare the right side picture with the left side. In the left side picture, the first criterion for Angle's class 1 molar relationship is well fulfilled, but the second criterion is not fulfilled. This type of molar relationship is called as pseudo-class I relation. This type of relationship is often found when the mesiodistal width of the maxillary first molar is less than normal. Now we will discuss the third criterion. The third criterion is that in class 1 molar relationship, the mesial palatal cusp of maxillary permanent first molar occludes in the central fossa of the mandibular permanent first molar. Now look at the pictures below. See when all 3 criteria for Angle's class the OI molar relation are present, then the premolars enjoy a cusp embrasure relationship on the buccal aspect and a cusp-fossa relationship on the lingual aspect. Look at these 2 pictures below. In the class 1 molar relationship, a cusp embrasure relationship is maintained between the maxillary canine and mandibular canine and first premolar, but the cusp tip of the maxillary canine remains slightly mesial to the embrasure. Also, the maxillary 4 incisors overlap the mandibular 4 incisors, and the dental midlines of both arches coincide with each other. According to Andrews, Class 1 molar relation is a part of normal occlusion, but in a few situations, molars are finished therapeutically in either Class 2 or Class 3 molar relation. When molars are finished therapeutically, either in Class 2 or Class 3 relationship, canines must be in Class 1 relation. Remember one thing, you can maintain either Class W, Class 2 or Class 3 molar relationship, but canine should always be finished in Class 1 relationship. This is very important from the functional occlusion point of view. Another thing is that finishing the molar in therapeutic Class 2 or Class 3 is equally stable as Class 1 molar relationship. The only issue is that you have to achieve a proper cusp-fossa relationship. You should never finish the occlusion in end-on molar relationship. Now we will discuss the key 2, which is crown angulation or mesiodistal tip of the crown. Remember, key 2 deals only with the angulation of the clinical crown of a tooth. It has no relation with the angulation of the whole tooth. Crown angulation or tip is the angulation of the long axis of the clinical crown of the tooth. Look at the picture. Crown angulation is the angle between the long axis of the clinical crown, that is FACC or facial axis of the clinical crown, and a line that is perpendicular to the occlusal plane. As the FACC is related to the clinical crown, this line may or may not pass through the root apex. If the crown of a tooth is normally angulated, the gingival portion of the long axis of each clinical crown should be distal to its incisal portion. The crown angulation varies from tooth to tooth. The long axis of the clinical crown for all teeth, except molars, is clinically judged from their mid-developmental ridge. This table describes the normal crown angulation of different teeth in the maxillary and mandibular arch. In the maxillary arch, the crown angulation of different teeth varies from each other, and the canine has maximum crown angulation. In the mandibular arch, the canine has maximum crown angulation, but all other teeth have almost the same angulation. The crown angulation, or tip, is expressed in degrees, either in plus or minus. A plus reading is given when the gingival portion of the long axis of the clinical crown remains distal to the incisal portion. Look at the first picture, which highlights the positive crown angulation of maxillary canine. A minus reading is given when the gingival portion of the long axis of the clinical crown remains mesial to the incisal portion. Look at the second picture, in which the crown angulation of maxillary canine is negative. When the crown of a canine is distally angulated, as shown in the picture below, it is usually considered as unfavorably angulated. This is important because you have to modify your mechanics during the comprehensive orthodontic treatment. Now, we will discuss how the variations in the crown angulation can affect the optimum occlusion. You all know that the heights of the clinical crowns of the maxillary anterior teeth are maximum among all teeth. As a result, their proper crown angulation plays a significant role in optimum occlusion. The degree of crown angulation of incisors also determines the amount of mesiodistal space they utilize in the dental arch, and thus has a considerable impact on anterior aesthetics and posterior occlusion. These pictures basically describe how the variation of a maxillary anterior tooth can affect the mesiodistal space in the dental arch. Situation 1 shows the normal angulation of a tooth and actual space consumption in the dental arch. In situation 2, the tooth is uprighted without any angulation. As a result, the space utilized by the tooth in the dental arch is less than normal. In situation 3, the tooth is excessively angulated and the space utilization in the dental arch is more than normal. We have discussed key 1 and 2. Now we will discuss key 3, which is crown inclination or labiolingual or buccolingual inclination. It is also described as torque. Crown inclination or torque is the buccolingual or labiolingual inclination of the long axis of the clinical crown. As shown in the picture, crown inclination is the angle between a line that is parallel and tangent to the FACC at its midpoint, that is facial axis point, and a perpendicular line on the occlusal plane. The crown inclination is expressed in degrees, either in plus or minus reading. A plus value is given when the gingival portion of the long axis of the clinical crown remains lingual to the incisal portion. A minus value is given when the gingival portion of the long axis of the clinical crown remains labial to the incisal portion. The crown inclination of the maxillary four incisors is positive. However, the crown inclination of the maxillary central incisor is more compared to the lateral incisor. In contrast to maxillary incisors, the inclination of mandibular incisors is slightly negative, and same for central and lateral incisors. The sufficient inclination of maxillary and mandibular incisors is essential to prevent their over-eruption and to maintain normal overbite. Thus, the proper inclination of the maxillary and mandibular incisors is very crucial for the retention of the deep bite corrected during the comprehensive orthodontic treatment. Also, for proper occlusion of the posterior crowns, optimum crown inclination of posterior teeth is essential. The lingual crown inclination of the maxillary canine, premolars and molars is constant and similar from canine to second premolar, but is slightly more so in the molars. When the torque is constant or similar in all the teeth in a segment of the dental arch, it is called continuous torque. In contrast to the maxillary arch, the lingual crown inclination of mandibular canine, premolars, and molars is, however, progressively increased from the canines through the molars. This type of torque is called as progressive torque. In this table, normal crown inclination of individual tooth in the maxillary and mandibular arches is summarized. From this table, you should remember that the torque is continuous in nature in the mandibular incisor region and maxillary canine, premolar, and molar region. However, the torque is progressive in nature in the mandibular canine, premolar, and molar region. The buccolingual inclination of the posterior teeth is critical for good intercuspation and for the prevention of interferences during mandibular lateral excursions. The crown inclination of the posterior teeth can be judged from the clinical assessment, that is, by evaluating the curve of Wilson. In the maxillary arch, the palatal cusps of the posterior teeth are slightly longer compared to buccal cusps. In the mandibular arch, the level of buccal cusps of posterior teeth is within 1 mm above the lingual cusps. The fourth key is rotation. In normal occlusion, all the teeth in the maxillary and mandibular arch should be without any rotation. You must remember that when an anterior tooth is rotated, it occupies less space in the dental arch. This is because the mesiodistal dimension of an anterior tooth is more compared to the labiopalatal dimension. In contrast, a rotated posterior tooth occupies more space in the dental arch. Thus, by derotating a posterior tooth, space is gained in the dental arch, and for the derotation of an anterior tooth, space is required in the dental arch. Even if all the teeth in the maxillary arch are well alignment, the mesiopalatal rotation of the first molars is very common, and there are few guidelines to identify the same. According to Ricketts, when the maxillary first molar is in normal occlusion and not rotated, the line touching the tips of distobuccal and mesial palatal cusps on one side passes through the distal third of the opposite side canine. Another is Chetlin and Ten Hoave's method, in which they proposed that maxillary first molars are considered to be well positioned when the buccal surfaces of right and left side molars are almost parallel to each other. Andrew's fifth key is the tight contact. There should be a tight contact point between the teeth. It is important as tight contact between the teeth prevents food lodgement, helps in the distribution of occlusal forces among multiple teeth, and also stability of the dental arch. The contact points of the maxillary and mandibular four incisors are located in the incisal third of the crown. For posterior teeth, contact areas are usually located in the occlusal third of the proximal side and slightly buccal to the central fossa. If there is a sign of genuine tooth size discrepancy, then spaces remain between the teeth, as shown in the pictures, where lateral incisors are small and peg-shaped. When there is a genuine tooth size discrepancy in such a situation, jacket crowns should be used for the correction of genuine tooth size discrepancies. In such cases, spaces between the teeth should not be closed during the orthodontic treatment. The sixth key is about the occlusal plane. The occlusal plane is an imaginary surface that is related anatomically to the cranium and theoretically touches the incisal edges of the incisors and the tips of the occluding surfaces of the posterior teeth. In normal occlusion, the occlusal plane should be flat to a mild curve of spee because there is a natural tendency for the curve of spee to deepen with time. When the occlusal plane is flat, the occlusal table for the chewing is maximum. The intercuspation between the upper and lower teeth is optimum, and the roots of the teeth remain parallel to each other. Thus, the masticatory forces are physiologic in nature. We have completed our discussion on Andrew's 6 different keys to normal occlusion and all about the static goals for the normal occlusion. Now we will discuss the functional aspects of normal occlusion. Remember one thing: static keys are very much essential for optimum functional occlusion. Functional occlusion goals are essential to attain and maintain an occlusal scheme that is in harmony with the rest of the components of the TMJ and neuromuscular structures. Roth suggested various keys to functional occlusion, and we will discuss them in detail. According to Lee, bioaesthetic occlusion is a concept that aims to achieve a healthy, highly functional, unworn chewing system that provides natural beauty. It is presumed that ideal static occlusal relationships are compatible with an ideal functional occlusion. According to Ricketts, the modern concept of ideal occlusion in orthodontics also includes all components of the temporomandibular joint. Thus, the position of the condyle in centric occlusion and all border movements of the mandible, as determined by the temporomandibular joints, need to be considered. Thus, the objective of functional occlusion, or nathological objectives of occlusion, is aimed at harmonizing the occlusal morphology with the closure of the mandible in centric relation and with lateral excursions of the mandible. Gazit et al. Recommended that all mandibular border movements must be checked for any interference. So any interference in the lateral excursions and protrusive movement of the mandible must be checked. The goal at the end of orthodontic treatment should be to achieve a canine-guided and mutually protected occlusion unless there are specific situations exist. In the functional occlusal goals, the intercuspal position and retruded contact position must coincide with each other. That is, centric occlusion, or CO, must coincide with centric relation, or CR. That means there should not be any interference when the mandible moves from centric relation to centric occlusion. At the end of comprehensive orthodontic treatment, One important thing is to obtain a stable centric relation of the mandible and all the teeth intercusp maximally at this position. All centric cusps should hit equally and simultaneously, and the occlusal stress should be directed as nearly as possible down along the long axis of posterior teeth. From centric relation to centric occlusion, all posterior teeth should contact equally and evenly upon closure, with no contact between the upper and lower anterior teeth. There should be a clearance of 0.0005 between upper and lower incisors. The overbite should be 4 mm and the overjet should be 2-3 mm after removal of the orthodontic appliance to allow a gentle glide path. During protrusive movement of the mandible, the anterior teeth should act as a group with the cuspids as the main guiding inclines to gently but immediately disengage or disocclude the posterior teeth. Thus, no lateral stress is distributed on posterior teeth during the mandibular protrusion. Also during the protrusive movement, 6 maxillary anterior teeth should articulate with the 6 mandibular anterior teeth and 2 premolars so that the whole protrusive load can be distributed on 14 teeth. This is an excellent example of a group function. When the occlusion is finished normally, the tip of the maxillary canines should be slightly mesial to the embrasures between the mandibular canines and first premolars, and the cuspid overjet should be 1 mm. In lateral excursion or eccentric lateral mandibular movement, only the canines on the working side should be in contact, whereas on the non-working side, there should not be any balancing contact. That is called canine-protected occlusion. Remember, in canine-protected occlusion, mandibular canine plays more crucial role compared to maxillary canine. During the lateral excursion, on the working side, the rotating condyle is braced against the bone or ligament, and on the non-working side, the orbiting condyle does not brace against the bone or ligament. Thus, during the lateral excursion of the mandible, no lateral stress is distributed on any posterior teeth. Here, we will discuss about the mutually protected occlusion. We have discussed that the posterior teeth protect the anterior teeth from lateral stresses during mandibular closure into the centric occlusion, and the anterior teeth protect the posterior teeth from lateral stresses during protrusive and lateral mandibular movements. This is called mutually protected occlusion, in which anterior teeth protect posterior teeth and posterior teeth protect anterior teeth during various mandibular movements. This picture shows the disocclusion of teeth in canine-guided occlusion. You can observe that during right and left side lateral excursions of mandible, only canines are in occlusion and disocclusion of rest of the teeth in the working and non-working sides. Now we will discuss few clinical implications: inadequate torque or inclination of max. Incisors result in too steep anterior lift and insufficient gliding path in protrusion. This leads to excessive lateral stress on the incisors, so appropriate inclination of the maxillary incisors must be achieved during the orthodontic treatment. Second molars are the most common site for occlusal interference. Thus, if required, it should be included in the treatment and its interference should be checked before removal of the appliances. Insufficient buccal root torque of upper molars leads to balancing and centric interferences. Thus, care should be taken to achieve adequate buccal root torque for the maxillary molars. In other words, the palatal cusps of the molars should not be overhanged. These are few references for your further reading. Thank you for watching the presentation.